Okay, we are live now.
Okay. So, good evening, postgraduates, and welcome to this 54th episode of All India Postgraduate Teaching Program, an initiative from ARC AIOS. We boast of this PG program as a program with a difference because, unlike other postgraduate teaching programs, we try here to cover the uncovered aspects of teaching programs like case presentations, the journal clubs, the OSCEs, and didactics rarely on topics which are not comprehensively available for you in the textbook. So today is our 54th episode, and today we will be having a didactic lecture on fundus autofluorescence, which had also been a long question in one of the MS finals. Besides that, the fundus autofluorescence, you might have the images shown during your OSCEs, so that is what we need to you to get familiarized with. Today's didactic lecture would be presented by Dr. Alok Sen, who is a medical superintendent and head of the department at Sadguru Netra Chikitsalaya, Chitrakoot, Madhya Pradesh. My special thanks goes to Dr. Chaitra Jaydev, who is a HOD and consultant at Narayan Netralaya, Bangalore. Professor Dr. Dhanashri Ratra, who is a senior consultant at Department of Vitreoretinal Diseases at Shankar Netralaya, Chennai. And my dear friend Dr. Dinesh Garg, who is a medical director at Advanced Center of Eyes, Ludhiana. I'm really thankful to all these three people for sparing their valuable evening with us for our postgraduates. Now, without much ado, can I request Dr. Alok Sen to share his screen?
Hello.
Yeah, Alok, go ahead. Full screen कर दीजिए. बस.
Yeah. So
Good.
are the slides there?
Yeah, visible.
And am I audible clearly?
Yes, great.
So thank you so much, sir, for this opportunity. And I hope I do justice with the trust that you have on me for this topic. So basically, my topic is how understanding the fundus autofluorescence. And so this is the outline of my presentation, where I would be discussing a little on, touching a little on basics of autofluorescence, the imaging techniques that we are using currently, interpretation, where I will be showing a lot of clinical cases. There are about 15, 16 clinical cases. If I am shooting my time a little, then you may ask me to stop whenever you feel like. But basically, it's more of a clinical presentation than a didactic lecture. And I have no financial disclosures to make for this presentation. Now, why fundus autofluorescence is because what I feel is this is one of the most underutilized modalities of retinal imaging. It has got a great advantage that it is non-invasive. It can be done very quickly. And moreover, it can provide you with the functional integrity of RP, which is very important in some of the diseases. We are all aware of fluorescent angiography, which we routinely do in most of our cases, where we know that there is a chemical fluorophore, which gets excited by a short wavelength of light. And when the electrons, they come back to their lower energy levels, they emit a light which is known as emission wavelength, which is usually longer than the excited wavelength. So this is the basic principle of fluorescence. Now, what is difference in autofluorescence is that there are intrinsic molecules which are known as endogenous fluorophores, and they are universally present everywhere in the body. And once the light strikes this, again the electrons, they go into higher energy level, and when they come back to the ground level, they emit a longer wavelength of light. So instead of a external or a chemical fluorophore, we utilize endogenous fluorophores in imaging autofluorescence. Now, the important thing is that the morphofunctional status of the living system influences the autofluorescence. So it becomes a very powerful resource for monitoring biological substrate of the condition. So here you can see that the RPE, which is under fluorescence microscope, you can see the fluorescence from the RPE. So where from the autofluorescent signals are coming. So if you recall your visual cycle on photoisomerization, the 11 cis retinal is converted into all trans retinal. So these are retinal aldehydes, and most of the all trans retinal is then reconverted into all trans retinol. Now, but some of these all trans retinal or retinal aldehydes, they undergo a non-enzymatic reaction with lipids in the outer segment of the photoreceptor to form lipofuscin, which is the major autofluorescence, fluorophore in the eye. Now, we also know that the outer segments, they are phagocytosed by the RPE. Of all the different functions of the RPE, one of the major function is phagocytosis of the outer segments. And hence, the major source of autofluorescence is lipofuscin in the RPE. And 90% of this lipofuscin in the RPE is coming from the photoreceptor outer segments, which are formed during the visual cycle. Now, this lipofuscin is deposited in the RPE as a result of the outer segment disc phagocytosis, and this cannot be degraded and tends to accumulate. As you can see here in this fluorescent microscopic picture at different years, you can see that the autofluorescence will increase as the retina ages. Now, there are other fluorophores also in the retina, and one is melanin, which is predominantly present in RP and the uveal melanocytes, and it has an excitation peak of 787 nanometer. Now, on conventional short wave fundus autofluorescence, we'll see what is it. The absorption this melanin absorbs the excitation light, that is 488 nanometer light, and reduces the autofluorescence signals. And we'll see the importance of this. Another fluorophore which is there in the retina is rhodopsin, which is concentrated in the rod photoreceptors. And this also absorbs excitation light and reduces autofluorescence signals. However, on exposure to bright light, this rhodopsin photoisomerizes, and this reduces the absorption of excitation light by rhodopsin and increases the autofluorescence. And this is what is known as bleaching effect. So we'll see how this affects the autofluorescence once in future slides. Now, the difficulty in imaging fundus autofluorescence is that these signals are very low, and there are pre-retinal structures that may impede the autofluorescence signals. So we have to find a way to overcome this. So in camera-based systems, what is done is to shift the excitation photons towards the red red wavelengths, so as to bypass the reduction of autofluorescence from the lens, which is causing the alteration of the blue autofluorescence. Now, the autofluorescence in flash camera-based fundus autofluorescence cameras is captured using a single flashlight, and the captured light is being reflected at different planes, and this reduces the contrast of the image. And I'll show you the difference between the two systems. Now, this is autofluorescence taken by the same camera using two different wavelengths. One in the center is the blue wavelength, and you can see that the contrast is decreased because of the impedance by the lens, which causes impedance of the blue rays. And this is with the green autofluorescence towards the right of the screen, extreme right, and you can see that there is an improvement in the contrast. Now, the other method of bypassing or reducing the impedance by the lens is using a confocal technology. Here, what it does is the confocal optics, which uses a pinhole, reduces light detection to a single optical pin and eliminating the scatter. So the other scattered light from other reflectance are eliminated, and this improves the contrast. However, the absorption by the macular pigments of this wavelength will cause an impedance of the fluorescence coming from the fovea, and the fovea appears dark, and we'll see it in the picture. So in confocal, what you do, you take use a laser which scans through the retina in a raster fashion, and you take multiple images, and the images are then averaged to reduce the noise, and then the average image are normalized to the piscals. The adjacent piscals are not normalized, and this improves the contrast. Now, this is a autofluorescence, which is two pictures of fundus autofluorescence. One is taken using a confocal system towards the left, and on the right, it is a camera-based green autofluorescence. So what you can see distinctly is that in the green autofluorescence, you can see the central fovea is less dark as compared to the blue autofluorescence. And this reflects the macular pigments which block the blue autofluorescence. The other thing that is clear is that the blood vessels are have less contrast with the green autofluorescence as compared to the blue autofluorescence, because the blood absorbs more of a blue light. Even the disc is darker in the blue autofluorescence as there are no fluorophores over the disc. Now, there is one more system that we are using, and that is wide field autofluorescence. And this is a picture taken from Optus. It provides a 200-degree of the fundus using an ellipsoid mirror. Now, the importance is that some of the disease, especially uveitis, you may have, or even in age-related macular dystrophies, degeneration. Now, people have noted changes in the peripheral retina as well. So this gives you a broader area of retinal or RP changes as compared to the standard 30-degree or 50-degree, or even with the Clarus, which gives you around 120-degree of the fundus view. So coming to interpretation of the fundus autofluorescence. Now, if you see the topographic distribution of autofluorescence signal, the fovea is usually black or dark because of the blockage by the macular pigments, lutein and zeaxanthin. The optic disc lacks fluorophores and hence appears dark. The blood vessels, because the blood absorbs blue light, and hence it also appears dark. And what you see is that the fundus autofluorescence has maximum fluorescence in the perifoveal area, near 7 to 15-degree eccentricity from the fovea. And this is because of the maximum metabolic activity here. So if you recall that the fundus autofluorescence, the autofluorescence is coming from the RP, and you now know that because in the fovea there is macular pigments, lutein and zeaxanthin, which block the blue light, and hence you have a dark fluorescence at the center. And since the RP photoreceptor or the activity is highest in the perifoveal area, you have a ring of or the autofluorescence is maximum in the perifoveal area. Now, when we talk about interpretation, there are two things. One is hyperautofluorescence, which appears white, and it indicates a sick RP, or hypoautofluorescence, which is dark, which indicates dead RP. So that's the basic difference. Now, increased autofluorescence can be because of accumulation of lipofuscin within the RP, or it could be because of loss of photoreceptors, which leads to because as we had discussed before, that photoreceptors outer segment, they also have rhodopsin, which blocks the RP autofluorescence. So once the photoreceptors are gone, you will have a transmission increase in autofluorescence from the RP. Similarly, as we had discussed earlier, if you bleach the retina, there would be an increase in autofluorescence. Now, the autofluorescence can also be more if the RP are stacked at the boundary of the geographic atrophy, or there is deposit of lipofuscin under the retina, as in some of the cases, as in CSR and other cases or best dystrophies, or under the RP as well. Now, decreased autofluorescence can be because of masking effect, something that is lying in front of the RP, like blood or a fibrovascular scar, uh, uh, or maybe a pigment. It can also be because of atrophy of the RP. More often, it is because of the atrophy of the RP. So RP is knocked off. So then you will have a decreased or dark autofluorescence or no autofluorescence. Now, one caution is, do not ever interpret FAF images in isolation, because there could be a lot of variation, and always try to correlate with findings on your fundus picture, OCT, and FFA. So that is one important thing that you should always remember. Never make a diagnosis based on an FFA image, FAF image. Now we'll next few minutes or 10-15 minutes, we'll go through some of the clinical cases. Now, the most common area where we use fundus autofluorescence is age-related macular degeneration, particularly the dry age-related macular degeneration. Now, in dry age-related macular degeneration, the characteristic finding is that of drusen's and RP alteration. Now, small drusen's may have variable autofluorescence, and autofluorescence may not be very useful in these cases. Large drusen's usually have a central halo, hypoautofluorescence with a surrounding hyperautofluorescence. And this ring of hyperautofluorescence is because of the RP hypertrophy at the edge of the drusen. Now, autofluorescence can be very useful in making or identifying reticular pseudodrusens, where you can see these round or ribbon-shaped hypoautofluorescence with intermingled normal autofluorescence, as you can see in the upper half of the autofluorescent image on the left side. So this is important because these cases are at very high risk of progression to advanced AMD. And reticular pseudodrusen is usually present on OCT above the RP. And you can see the OCT frame here, which you can see these conical lesions which are above the RP. So this is important. And fundus autofluorescence has a good sensitivity of around 80% to detect these reticular pseudodrusens. Now, another important aspect is to identify geographic atrophy, and which is an advanced AMD. And there are areas of dead RP or RP atrophy and atrophy of the outer retina as well as the choriocapillaries. And by definition, it is said to be geographic atrophy if the area is more than 175 micrometers in diameter. Now, these are on fundus autofluorescence, these appear as well-delineated areas of profound decrease in fundus autofluorescence as the RP is completely lost. And there is areas of surrounding hyperautofluorescence. Now, this is important, as the surrounding RP, which is autofluorescence, it is basically a sick RP or a RP which is not functioning optimally. And new areas of atrophy will develop in the periregional hyperautofluorescence areas. Now, this is a case where you can see that there is progression of, you can document progression of geographic atrophy over a period of time on just doing a fundus autofluorescence imaging. Now, there are certain risk factors for progression of geographic atrophy, and these include a large lesion size, multifocal lesions of geographic atrophy, non-foveal location, and if you see perilesional hyperautofluorescence, either diffuse type or granular type or a banded type as shown in the figure. Now, autofluorescence may not be very useful in wet AMD. However, it can show areas of geographic atrophy developing as we treat these patients. Areas of scarring or fibrosis appear hypoautofluorescence, and the actual area of uh, the new vessels or subretinal neovascularization will have variable autofluorescence. Now, the dark areas on fundus autofluorescence could be because of block, as you can see here in the picture of on the right of your screen, and so these fundus autofluorescence in patients with wet AMD is more useful to detect geographic atrophy during treatment course. Now, other diseases that can be in which fundus autofluorescence is generally used is inherited retinal diseases, and the most common of which is retinitis pigmentosa. And you all know that it is characterized by photoreceptor degeneration, RP cell migration in the form of bony spicules, vascular attenuation, and vascular pallor of the optic disc. Now, what you see on fundus autofluorescence is this Holder ring sign, which is a just so this sign is basically a hyperautofluorescence ring, which is seen at the junction of abnormal and normal retina. And this indicates a decreased RP function at this point, and it corresponds to the edge of an intact EZ on or ellipsoid zone on your OCT. Now, the peripheral retina may show variable hypoautofluorescence, and this is because of the RP atrophy. The bony spicules that you see, the pigmentation that you see, also appear hypoautofluorescence on fundus autofluorescence in imaging. The other common retinal pathology or hereditary dystrophy is Stargardt's disease. What you see here is classic beaten bronze appearance of the macula because of the RP atrophy. And this is surrounded by pisiform yellow-white flecks. And these appear to be the central atrophy. RP atrophy appears dark on fundus autofluorescence, while the periphery, the flecks, they appear hyperautofluorescence to start with, but as the atrophy sets in, they would appear hypoautofluorescence. So this is a classic picture on fundus autofluorescence of Stargardt's disease. Of note is that the peripapillary retina appears to be spared in this disease. Now, another disease that can be picked up very well on fundus autofluorescence is Best disease. And here you have vitelliform deposits under the retina, and these may alter over a period of time. And there are different stages that have been defined. And this is associated with neurosensory detachment. Now, you can see this case where you have a bilateral symmetrical neurosensory detachment, and you can see that those shagging of the photoreceptors and some of the deposits over the RP, and these appear hyperautofluorescence on fundus autofluorescence, and you can see these hyperautofluorescent dots. They correspond to the outer segments which are shagging that is seen on the OCT. The dark area is because of the blocked autofluorescence due to the fluid, and at times because of the RP atrophy that sets in. Now, this is a case of cone dystrophy where the patient usually presents with day blindness and photophobia. And you can see that there is a loss of outer retina at the fovea. And when you see do an autofluorescence, you'll see this uh, uh, bull's eye like maculopathy, where you have these stippled hyperautofluorescence surrounding the fovea, uh, as you can see here in these two images. Now, FFA can also be helpful in monitoring uveitis. And one of the common diseases that we look into with using an FFA is serpiginous-like choroiditis, which is a multifocal placoid uh, chorioretinitis, or it is a choriocapilloropathy, wherein these placoid lesions, they enlarge into a enlarge and coalesce into a confluent lesion and with an advancing edge in central healing. Now, usually this is associated with significant vitritis, and the possible etiology in an TB endemic country like India is ocular tuberculosis. Now, on fundus autofluorescence, actually you can monitor the disease activity very well in these cases. The active disease will usually appear as hyperautofluorescence halo at the margin, as you can see in the first figure. And this slowly turns into a very distinct hypoautofluorescent margin. And the inner aspect is hyperautofluorescence, predominantly hyperautofluorescence, as the lesions start healing. And over a period of time, the hyperautofluorescence or the granular hyperautofluorescence becomes more hypoautofluorescence. Finally, at the heal stage, it is completely dark or hypoautofluorescence. So this pattern helps you in identifying whether the lesions are still active or they have started healing. Now, the other pathology in which fundus autofluorescence is useful is nudes. Here, what you see is multiple faint white lesions, predominantly in the posterior pole. And these lesions on OCT appear to be hyper reflective lesions in the in the outer retina, with disruption of the photoreceptors. Now, because there is disruption of the photoreceptors, they will cause a hyper autofluorescence due to unmasking of the RP, as you can see here in the picture. So this is a case of nudes. Similarly, this is a case of multifocal choroiditis. And what you see in that the active lesions, you have a central hypofluorescence and a margin of hyperfluorescence, while the inactive lesions are dark because of loss of RPE. So this is a case where you had this initial lesions which were hyper autofluorescence, and as the disease resolved, you can monitor. You can very well see that the hyperfluorescence has gone and the lesions turn more of hypoautofluorescence. Another disease which has a very classical fundus autofluorescence finding is acute zonal occult outer retinopathy. And in this, you will have a trizonal pattern where you have a normal fundus autofluorescence in the outside the lesion. And at the margin or a demarcation line, there is a speckled hyperautofluorescence where the RP are still functioning, but they are sick. And within the lesion, there is hypoautofluorescence because of dead RP. Now, acute syphilitic posterior placoid chorioretinitis is another pathology where fundus autofluorescence can be used for diagnosis. Here, what you see is a large placoid lesion, which is predominantly in the posterior pole. And on OCT, you see these nodular elevations at the level of RPE. And this is thought to be the photoreceptor RPE complex because of the dying RPE. And this on autofluorescence, you will see these pinpoint hyperautofluorescence, which corresponds to the nodular thing that you see on the OCT. Now, this is an interesting case of a 37-year-old female who was being treated on treated on the lines of intermediate uveitis with steroids and immunosuppressive therapy. Now, what you see on autofluorescence is this granular stippled hypoautofluorescence. And on OCT, you see these sub-RP deposits, and there is diffuse infiltration of the retina. Now, this is seen in patients with primary vitreoretinal lymphoma, and the hyperautofluorescence that you see is basically the RP proliferation at the edge of the lymphoma cells, and the lymphoma cells themselves, they cause block fluorescence. So you will have these granular type of hyperautofluorescence in patients with primary vitreoretinal lymphoma. Now, coming to macular pathologies, the most common macular pathology in which we use fundus autofluorescence is central serous chorioretinopathy. And we all know that it is in an acute state, it is characterized by leak at the level of RP and neurosensory detachment, while chronic cases have atrophic and degenerative changes of retina and RP. Now, FAF tells you about the extent of RPE damage and the stage of the disease. Now, this is an acute CSC. What you see is a blister-like neurosensory detachment on the fundus picture. And you can see on the OCT as well, the neurosensory detachment. So when the patient presents in an acute stage, the fundus autofluorescence may not be very revealing. So it could be just an ISO or sometimes even an hypoautofluorescence. But as the disease evolves, because of the collection of lipofuscin, or which is there in the outer segments which deposit under the neurosensory retina, the fundus autofluorescence will increase. And as you can see, after a period of a month, you can see that the fundus autofluorescence shows much more than it was in the presentation, and it tends to gravitate. The fundus autofluorescence is more in the inferior half, as you can see here. Fundus autofluorescence can be more helpful in making diagnosis of chronic CSC, where you can see these gravitational tracts of fluid of hyperautofluorescence. Now, this hyperautofluorescence is basically because of the loss of the photoreceptors, and there is increased transmission. It can also be because of the lipofuscin which is being deposited because of the shed photoreceptors. Now, there could be patchy areas of hypoautofluorescence which suggest RPE damage or loss. So, as you can see here, in the left, this is right and left eye of the same patients. The left eye shows an acute CSC, while the right eye shows evidence of old CSC in the periphery. Macular telangiectasia type 2 is another disease where fundus autofluorescence can be helpful. And it is characterized basically by neurosensory atrophy. Basically, it is a disease of the molar cells. And there is also loss of macular pigments, lutein and zeaxanthin. So as we recall that lutein and zeaxanthin would block the fluorescence coming from the RP at the fovea. So we would expect more autofluorescence in these cases, in cases with MACTEL at the fovea. So this is a fundus fluorescent angiography. And as you can see on fundus autofluorescence, now normally the fovea appears dark on fundus autofluorescence. But because here the foveal pigments are not there, there is transmission hyperautofluorescence, as you can see in the left eye. And the autofluorescence is more in the temporal half in these cases. For some reason, the area of the retina temporal to the fovea is more involved. This is a case which we recently saw, and he was a patient of sarcoidosis who was on HCQ therapy for long. And what you see on fundus picture and OCT is a central sparing, a ring of atrophy of RP around the fovea. And the fundus autofluorescence shows a bullseye type of maculopathy. And this is a case of HCQ toxicity. And you can also see that there is some area of hyperautofluorescence. So the RP is still very sick around that area of atrophy. Now, in fundus autofluorescence can be used for monitoring patients on HCQ. The initial and in early stages, you will have a ring of hyperautofluorescence, which later on, because of atrophy of the RP, will have this kind of hypoautofluorescence. So it can be used for monitoring maculopathy in patients who are on HCQ therapy. Now, coming to optic nerve disease, now this patient was referred to us as a case of papilledema. You can see right and left eye of the patient. There is the margins of the disc are blurred with elevation. And what you see on B scan are this optic nerve head drusen. Now, optic nerve head drusen on normal fundus autofluorescence, as we have seen, the optic nerve head is dark as it lacks fluorophores. Now, in optic nerve head drusens, there is deposition of mitochondria, which also has porphyrins, which are fluorophores, and they actually give rise to this kind of autofluorescence, especially if the drusens are superficial. Now, in cases of macular hole, the fundus autofluorescence can help you to differentiate a true hole from a pseudo hole. Now, we all know that the central part of the fovea in fundus autofluorescence is dark, while in presence of macular hole, because there is no pigments, there is transmission hyperautofluorescence at the center. And what you can also see on fundus autofluorescence is the redistribution of the foveal pigments because of the cystoid macular edema, and you can see those dark striations around the macular hole. The left eye appears to have a normal fundus autofluorescence. Now, what's new in fundus autofluorescence? The new thing is near infrared fundus autofluorescence. Here you use an excitation photon of 795 nanometer, while the emission range is more than 800 nanometers. Now, this will the fluorophore which is stimulated with this is not lipofuscin but melanin, and hence it helps in topographic distribution to identify topographic distributions of melanin. And you can see the difference between the right and the left image. The right one is the blue autofluorescence where the fovea appears dark, while the left one is the near red autofluorescence where the fovea appears bright. Now, this helps you to identify a area of atrophy, which is subfoveal. So in blue autofluorescence, the subfoveal atrophy may not be clearly visible, and which is more effectively delineated on near infrared autofluorescence. The other thing is the fluorescent lifetime imaging. It is very difficult to discuss this in detail in this class, but in general, what is done is there is quantification of the average time. Now, we know that when the light falls on these fluorophores, the electrons are absorb the energy and they go into the higher level. And when they come back to the ground level, they emit a light of a longer wavelength. Now, this time interval between the excitation to the fluorescence is measured, and it is displayed as fluorescent lifetime imaging. And this is now being used in various pathologies, including AMD, Stargardt's, and other diseases. So to summarize, it is a quick non-invasive technique of examining health of the RPE. It may assist in diagnosis and monitoring of disease activity. The extent of disease on fundus autofluorescence may be far more than that on visible on fundus pictures. But uh, remember, it should be it should be used, not never used as a standalone investigation for diagnosis. But you should know that it can be of great help in many of the retinal and retinochoroidal pathologies. Thank you so much.
Thank you, Dr. Alok, for wonderfully comprehensively covering the whole topic and having such a wonderful collection of images. Kudos to you and your team at SNEC. Okay, so now the topic is open to the discussion for highlighting and adding some things. So why not we start with Dr. Chaitra, the junior most amongst all of us.
Thanks for this opportunity. And I think it was very well covered. And one important thing that was spoken about was the recent advances of near-infrared autofluorescence, NIR-AF images. And I think what was mentioned and to add to it is it's commonly using the ICG mode of the SLO without any dye injection. Most importantly is that they are confined to the RP monolayer and the melanin in the choroid. So that's important. And second thing is we only focus a lot on AF of the retina. We should understand that you can have autofluorescence even from the other structures of the eye. So, sometimes it can actually impede the image quality depending on which imaging modality you're using. Whether, the lens, the cornea, all of it can also have some sort of autofluorescence as well. And Dr. Alok has already mentioned that a prime importance of autofluorescence, because it denotes the function, is not only the morphological appearance of each one of them, which helps in diagnosis, but also prognosticating and follow-up. Some of the newer studies have actually shown that when you see, abnormal autofluorescence signals from the edge of the atrophy, they tend to progress more rapidly, the atrophy, than those that do not show any abnormality at the edges of the. So these are very subtle changes, but they're still important because they might actually show you images during your OSCEs and ask you, what do you think is the prognosis for this particular patient, especially if you have a retina examiner. Otherwise, most often it's quite simple and straightforward, the images that they show you. If you can just identify abnormality and what is that abnormality, I think that's more than enough, because sometimes they throw a googly at you and show a normal image and ask you to identify anything abnormal. And I think that's most of what I wanted to tell you all. And of course, the three different devices. Alok, I just wanted to ask you, which is your favorite among the devices that you have?
Spectralis we use quite often because it gives the blue autofluorescence gives you information about the macular pigments as well. So that is what we prefer. But of course, wide field autofluorescence now we are doing quite often, especially in our uveitis cases, where you can identify peripheral lesions pretty well on autofluorescence as well.
One other thing is, I think RIP, initially it presents differently and subsequently much more differently, as it starts healing. So if there are any retina fellows listening in as well, I think that's again a very important thing, because there is reappearance of FAF within the area of RP tip. So that can again be a confounding whether it's a recent or healing sort of a RIP. So that's about some of the inputs that I had.
I think wonderfully put it together. For postgraduates, remember, if you are getting a black and white image of a retina and you are asked to identify, remember, in two conditions, only two situations, you have black disc. Any one of you can highlight further about it so that helps them out. Dinesh, Dhanashri, in a black and white. So this is all subtle things which they should remember, I believe, initially.
Yeah, this is very important because black and white image can be either a fluorescein angiogram or it could be one of these fluorescein autofluorescence. So you need to look at the disc. If the disc is black, then it is not fluorescein, but it can be the autofluorescence. So you have to look at the disc and the vessels. So this is a very important point which Dr. Prashant has brought out. And second thing is for the PGs, maybe as we are on the basics, when we were doing our PG and fellowship, there were two terms which were very favorite of examiners. One was called autofluorescence and another was called pseudofluorescence. So we would always be asked what is the difference between autofluorescence and pseudofluorescence. So these are terms which were used when we had those film cameras, not the digital cameras that we have now. So in the film cameras, the filters had to be put in when you are doing this fluorescence and autofluorescence. So pseudofluorescence was a term which was used when there was a mismatch of the barrier filter and excitation filter. So that would cause a kind of a whitish appearance to the film, and that was called as a pseudofluorescence. But autofluorescence is, as mentioned very nicely by Dr. Alok Sen, is a property of the fluorophores to fluoresce even without the injection of a dye. So if you see a fluorescein right at the beginning of your fluorescein run, when you see a fluorescein film, right at the beginning, if you see, then that would be an autofluorescence. And typically the optic nerve drusen or the retinal drusen were the ones which were autofluorescent. So, but now, of course, we don't have these terminologies because we are now using the mechanical digital cameras, and the filters are like, automatically matched. So we don't have to deal with this anymore. But I think if some of the older examiners, they might ask you these terms. So it would be good to be familiar with these terms. And Alok has covered the topic very well. And he has actually touched upon all the important points in each entity. It's a very large topic, but it's covered very well. Maybe I would just like to highlight that it is basically tells you about RPE function. So if you want to know about RPE function, then you do the autofluorescence. And if you want to know about the capillaries, then obviously you have to do the fluorescein angiogram. And like you mentioned, it is not to be done I mean, you cannot interpret autofluorescence alone. You need to have the fundus photo with you to interpret, because it depends. The autofluorescence will change with time. It will change as the lesion evolves. So you cannot interpret just based on the autofluorescence image alone. You need to have the fundus photo also with you. But sometimes there are situations like Alok also showed, especially if CSR, the fundus will look absolutely good, but the autofluorescence will show you a lot of changes. So that reverse also is possible.
So, yeah, I think Alok has covered it very well. So I just wanted the postgraduates to know that this is basically a kind of, as he has highlighted, that you can't interpret autofluorescence in isolation. It is more like a multimodal imaging, like you have seen a fundus photograph, color photos, photograph, red-free photograph, angiogram, as well as the autofluorescence. And then you make the diagnosis. And of course, it is more functional outcome which the autofluorescence gives. And sometimes you might get that ICG image also. There, that choroidal vasculature will be more visible. So it's always sometimes it is difficult to differentiate between whether you are dealing with what kind of modality it is. And in ICG imaging, we do more so for choroidal lesions or for posterior uveitis and things like that. And I think other thing I just wanted to add, is it like the ethambutol toxicity will also give a similar picture, or I just wanted to know, maybe Alok has a better experience both in.
Ethambutol basically affects the optic nerve. So ethambutol, I am not aware whether it gives the similar kind of picture on fundus autofluorescence.
Okay. Because ethambutol also affects visual acuity, and of course the optic neuritis, as well as even the streptomycin also affects the optic nerve. So these are a few things which we wanted to add.
Great.
So one thing, if you see a fundus picture with a dark disc, dark blood vessel, and dark fovea, then you are reading a fundus autofluorescence.
Correct.
That's the basic difference
Yeah, basically because
you have to keep in mind when you are appearing for exam.
At a postgraduate level, very well put across by Alok. A black and white photograph, black disc, black vessels, and black macula is a fundus autofluorescence. If you see a black disc with some dyes here and there and ICG pattern, choroidal vessel standing out, it is most likely to be an ICG. In a fluorescent angiography, again, you will have a white disc. White means the dye will make it fluorescent. So this is what you should remember. Do not falter at the very first step when you are given a suddenly in a NOSCI this particular presentation. So I think we had a wonderful discussion over all this. Any more inputs from any of the senior discussants? Chaitra, you are a person from a institute which is known for diagnostics in ophthalmology.
Yeah, I think some of the more basics.
Words are dropping, Chaitra. Can't hear you.
But I have unmuted.
Now we can hear you. Yes.
Some basics, they expect you to know.
Chaitra, again you are not heard. You come closer to the mic probably.
Yeah.
Can you hear us, Dhanashri?
Yeah,
No, no,
I can hear.
No, we are not able to hear.
I'm not able to hear. I think, very well pointed out by Alok also, autofluorescence is really very important in these inherited retinal diseases because many of the inherited retinal diseases sometimes may be difficult to interpret just based on the fundus. They may have overlapping features. And again, if the patient wants to know how it is progressing and all, then again, that is autofluorescence is really very helpful. And there is one finding which is described, it's called a Robson-Holder ring, which is a ring described by Robson and Holder, which is a hyperfluorescent ring, which is seen around the macular area. And that actually indicates the junction of the degenerated and the normal retina. And in the normal, in the sense, better retina in the macular area. So it is typically described in retinitis pigmentosa, but it can be seen in many other disorders also, like bone rod dystrophy and other inherited retinal disorders. So I think it is important to remember this one sign in the autofluorescence.
There's one question from in the postgraduate group for any one of you can answer. In which conditions should we use FAF only, and where can it be a diagnostic indication?
Only
I think Alok enlisted everything. I mean,
No.
almost everything that he showed was, and he said it should never be used exclusively. It should be used in combination. But I think AMD and inherited retinal disorders is very, very paramount. I think a lot of our patients, and of course, uvea, these will actually help even to plan the progression, to look for the progression of the disease and healing patterns also.
Probably what he meant was usually the examiners ask where in which particular condition you would like to do this only investigation as a diagnostic modality. Probably that's what he might be hinting at. So do we have certain diagnosis, classic diagnostics where FAF is mandatory and the only indication which can help you in reaching out diagnosis? That's what probably the student might be meaning it. I don't know.
You can say in drusen or in dry AMD where if you want to serially do it over a period of time and see the progression.
One condition which I can think of is the autosomal recessive bestrophinopathy, because in that the autofluorescence is really very diagnostic. And if you see the autofluorescence itself, you can diagnose this autosomal recessive bestrophinopathy. You need not even do any of the other tests. So you will see multiple lesions of hyperfluorescence around the macula. There are multiple, not just, of course, you will have the best vitelliform type of lesion at the macula. Along with that, you will have multiple other hyperfluorescent lesions all around the retina, all around the posterior pole. So I think that is a very, very diagnostic sign.
Okay, good. The other thing which I would just bring to a discussion is, since we have a Mirante by NIDA, there is another way of looking at the retinal pigment epithelium in physiological and pathological conditions. And here you see the diseased RP as a bullies. And in fact, when we have done a small study at our place, the extent to which the RP is diseased is more significantly seen compared to the fundus autofluorescence. So the diseased RP is better picked up by doing a retro mode of the Mirante. So you can see the extent of the disease, and many a times you will be surprised that the disease is much more than what a FAF or a color photo can pick up.
Sometimes they might also, if they have access, give you multicolor imaging. So, that's something that you should know. And you can also do a good correlation with the multicolor imaging. The blue reflectance and the green reflectance could help add to your knowledge about FF also. But primarily, I think you just need to know the basics of when you have the reduced fluorescence, whether it is reduction in the RP lipofuscin or increased RP melanin content or increased fluorescence. When do you see? I think if you know those two basics, I think that should be more than enough, and that will almost cover all the diseases that Alok has spoken about.
Great.
Yeah.
So any more inputs? Alok, the last
Final say.
final say it so that we can then wind up and say bye-bye. And
One one important clue that you may be dealing with macular dystrophies would be a very symmetrical presentation in both the eyes. So if you have, as ma'am said, that Best dystrophies, usually these dystrophies or or hereditary degenerative conditions of the retina, they have a very symmetrical kind of presentations that can help you in making a distinction between hereditary and acquired diseases.
good. So that stands true for all the hereditary degeneration versus the acquired thing on any diagnostic modality. You should remember that they are usually symmetric. They might be sometimes a bit ahead one of the eyes, but usually they are symmetric in nature. That helps you in telling whether it's a hereditary degenerations versus any acquired diseases, besides the other point which he has spoken about. So I think, Alok, I need to thank you profusely for giving us such a beautiful collection of sharing your beautiful collection of fundus autofluorescence. I never thought we can have such a single person can have such a big collection, almost like an atlas of it. Good. Thank you once more for that. And
Thank you.
of course, the discussant, Dr. Chaitra, Dr. Dinesh, Dr. Dhanashree, for sparing their valuable evening for our postgraduates. They are all indebted to you, and it's my duty to thank on behalf of them profusely for adding further insights into this slightly difficult looking investigative modality of retina. So thank you, everyone. So postgraduates, it's time for us to wind up. It's time for us to say bye-bye till next Thursday. Again, we will be meeting on following Thursday at 8 p.m. with some new topic. Till then, bye-bye from all of us. Bye-bye and thank you. Thank you, everyone.
Thank you, Dr. Prashant, for the
Thank
opportunity.
you, Prashant. I think we also learned a lot. Thanks a lot.
Thank you, and very well presented by Alok.
Yeah.
Thank you.
Yes.
Thank you, ma'am.
Super.
Goodbye. Good night.
Good
Good
night.
night.